Good morning, everyone. Thank you, organizer. And I bring my greetings from beautiful city of Kathmandu. So I'll be talking about concurrent chemoradiation. My previous speaker talked on radiation aspect of it. I'll be talking about chemotherapy aspect of it. So when you talk of locally advanced, it includes stage 3, and we know stage 3 has subgroups, 3A, 3B, 3C. In N3 disease, there is no discussion, it's concurrent chemoradiation. The discussion now is much on the N2 disease. Now they're just saying that all N2 diseases are not the same. They can be incidental, which found in intra-op and post-op, discrete PIT3 positive central tumor or suspicious node, and infiltrative, where there are multi-station and indistinguishable from tumor. In infiltrative, it's concurrent chemoradiation. Yes, in single nodal station, less than 3 centimeter, much of the discussion has been done about neoadjuvant chemo IO followed by surgery. But most of our patients, these are only done in very specialized center, and most of the patients from our part of work actually undergo concurrent chemoradiation. So, as my previous speaker said, concurrent chemoradiation is very toxic to start with. So, how many of the patients who are eligible for concurrent chemoradiation actually go for concurrent radiation? So, data has been different from different countries. From UK, they say only 1/3 of patients actually go for concurrent chemoradiation. From US, Western Europe, and Japan, it's very high. It's 2/3 of patients actually go for concurrent chemoradiation. In Canada, it's 50-50. So earlier there has been talk about either sequential chemoradiation or concurrent chemoradiation is better. So this debate has been closed by publication, this meta-analysis from JCO 2010 by Operina et al. This includes 6 randomized controlled trial, and it shows 5-year overall survival. If you see in Kaplan-Meier, it shows 5-year overall survival of 4.5%. And in concurrent chemoradiation arm, cisplatin was used in 5 trials, either on a daily basis as single agent in 2 trials or combined with other drugs in 3 trials. And carboplatin was administered in only 1 trial. So after this meta-analysis, it was said that in concurrent chemoradiation, platinum doublet is the standard of care. But there has been, these are the details of the 6 trials, and you can see chemotherapy used with either cisplatin or carboplatin with vinblastine, etoposide, vindaxine, mitomycin. So there has been changes in the chemotherapy regimen in the stage 4 disease. So there has been talk, can we replicate it in concurrent setting? So this was the paper published in 2013 by Liu et al. It includes stage 3 unresectable NSCLC, and arm A has carboplatin and paclitaxel weekly for 6 weeks along with radiation, and arm B has then standard of care cisplatin and etoposide. However, the results were similar overall survival with median 20.7 in arm A, but it was not statistically significant. However, the toxicity was significantly lower, especially hematological toxicity in carboplatin paclitaxel arm. Another paper published in 2016 in JCO, the Proclaim trial, which included stage 3A, 3B unresectable non-squamous NSCLC, where pemetrexed cisplatin was given concurrently with radiation for 3 cycles and consolidated by 3 weekly for 4 cycles, was compared with then standard arm of cisplatin etoposide. And also this was also consolidated by platinum doublet for 2 cycles. The results were not so encouraging. The overall survival was similar. However, the toxicity was significantly lower in PEMCIS arm. Another publication published in Oncotarget in 2016 by Zhao et al. It was also for stage 3 unresectable non-squamous NSCLC, where PEMCIS was compared with cisplatin etoposide. The results were not so encouraging, with similar overall survival with lower toxicities. So with these results, there was a thought, can we do something more? Can we add something more? And this was a famous RTOG 0617 trial, which was quoted by previous speaker also. It was 4-arm trial with standard RT, 60 gray versus 74 gray, with or without cetuximab. All arm chemotherapy was paclitaxel carboplatin weekly, followed by paclitaxel carboplatin 3 weekly for 2 cycle consolidation. However, there was no difference in PFS and OS, and after this trial, best regimen was still paclitaxel and carboplatin with 60 gray RT. So this was a network meta-analysis which almost guide the concurrent chemoradiation in today's era. It was published in BMC 2022. It included 22 studies with 18 regimens. 5 of the regimen was single agent with cisplatin, 5 with paclitaxel carbo and neraplatin. 7 was cisplatin doublet with etoposide, PEM, DOSI, S1, vinorelbine or Pacli, and 4 were carboplatin doublet with Pacli, PEM, irinotecan or etoposide. And 2 trials included mitomycin and mitomycin with cisplatin and etoposide etoposide cisplatin with amifostine. So this network analysis, and you can see the population with Asian, Caucasian, there was a mixed population, so it will reflect all the populations. So this trial extensively looked on the overall survival rate. It included 1 year, 2 year, 3 year. This is the Sukra plot of efficacies of different regimens. And this also evaluated extensively the side effects, toxicities. And this is the Sukra plot of toxicity of different regimen. So what this meta-analysis shows that 3-year overall survival rate of cisplatin etoposide, paclitaxel carboplatin, and PEM-CIS were relatively higher compared to other regimen. However, the toxicities of paclicarbo and PEM-CIS were relatively lower. So the cluster analysis of efficacies and toxicities of chemotherapy radiation demonstrated that carboplatin, paclitaxel, and PEM-CIS regimen had better efficacies and lower toxicities, and maybe the best regimen in treating this with concurrent chemoradiation. But at today's scenario, if anyone asks me what is the standard of care in this group of patients, everyone will agree it's a Pacific regimen. So here, the 5-year overall survival with durvalumab arm was 42.9% versus 33.4%, and 5-year PFS was 33.1% versus 19%. But sometimes we are so obsessed with durvalumab that we forget this patient actually got concurrent chemoradiation on the first place. And what was those chemotherapy? It was 2 or more cycle of platinum-based chemotherapy contain etoposide or any platinum doublet with etoposide, vinblastine, vinorelbine, pacli, and dosi or PEM. So here, any platinum doublet was allowed in platinum arm, concurrently with definite radiation of 54 to 66 gray. So there was not much to choose from here. In EGFR mutated arm, the standard of care now is the LAURA protocol. Here, the median PFS was 39.1 months with osimertinib versus 5.6 with placebo, and 3-year OS was 84% with osimertinib and 74% placebo. But here also we have to remember that this patient actually undergot chemoradiation on the first place. The trial design was very interesting. Actually, in LAURA arm, they actually included both concurrent chemoradiation and sequential chemoradiation as 2 arms. So they were also trying to compare if CCRT or sequential are similar. So which chemotherapy was used in LAURA? It was platinum-based chemo regimen. It's also nothing to choose from. It's platinum doublet with either etoposide, vinblastine, vinorelbine, pacli, dosi, or PEM. Gemcitabine was permitted only as in sequential chemoradiation out before radiotherapy. So there are only interim results published. Final results are awaited to see if there is any preference of sequential or concurrent chemotherapy. So from all this result, we can say that if we see the best efficacy regimen, it's platinum doublet of paclicarbo, PEM-CIS, PEM-carbo, cisplatin etoposide, or cisplatin vinorelbine. They don't have actually any difference when efficacy is concerned. But when you see the second part, the toxic part, PEM-CIS and paclicarbo are definitely less toxic than other regimen. So when we combine these, maybe paclicarbo and PEM-CIS are drug of choice when you use concurrent chemoradiation. So how this regimen, best regimen are given? Paclicarbo are usually on most of the trial given weekly with pacli 45 to 50 mg per meter square and carboplatin AUCT. PEM-CIS are given 3 weekly, cisplatin 75 mg per meter square on day 1 and PEM 500 mg per meter square on day 1 every 21 days for 3 cycles. And to consider it concurrent, we should give at least 2 cycles of PEM-CIS along with radiation. And cisplatin etoposide a very unique regimen with cisplatin 50 mg per meter square and day 1, day 8, and 29 and 36, and etoposide 50 mg per meter square and day 1 to 5 and day 29 to 33. So I would like to end my talk with this, but I have to end this by, however technique we may say, but we can say maximum number of life with cessation of tobacco. So awareness of tobacco control is the best.
So thank you so much for presenting it so well. So since the organizers asked me for no more question, but the bottom line is that every patient is individual, whether to give sequential, whether to give concurrent, what regimen to use, whether to use a single agent, whether to give a combination. I think it is a very much individualized decision, and that should be rated depending upon so many factors that the patient has come to us. So with this, I thank you so much, and I think we have come up with the end of this session, I suppose.